Shall we start?
Anand, has Anand joined? Anand, one of the facilitation. Then President and Secretary.
So we will start. Good evening, everybody. Welcome you all for the focus CME on CME for practicing pediatricians, organized by NNF Kerala, hosted by IAP Thrissur and Thrissur Neonatology Forum. Under the leadership of Dr. T.G. Ravi, NNF Kerala is active doing various projects since May. Their action plan, Mother's Milk, includes educational and training program for doctors and other health professionals. Today, we are gathered for the state-level inauguration of Focus CME of Pediatricians to update neonatology for practicing pediatrician. With the permission of the President of NNF Kerala, shall we start the program?
Sure. Please.
We will start the program with silent prayer. Thank you. Next is official welcome address. I am Dr. Rajagopal, President of Thrissur Neonatology Forum. Respected President of NNF Kerala, Dr. T.V. Ravi, today's chief guest, Dr. T.P. Jayaraman, other faculty members, professors, seniors, distinguished guests, and my dear friends. Today, we have gathered for the official inauguration of the Focus CME for practicing pediatrician organized by NNF Kerala, hosted by Thrissur Neonatology Forum and IAP Thrissur. This program will help to update recent developments in the field of neonatology. Without delaying, I will straight away go to my duty. As you all know, that under the leadership of Dr. T.R. Ravi, NNF Kerala is doing a lot of projects, and one of its kind, basically to update the knowledge of practicing pediatrician in neonatology. A program has been organized as Focus CME, and today is the official inauguration of the program. I welcome the President of NNF Kerala, Dr. T.V. Ravi, to the program.
Thank you.
The inauguration of the state-level academic activity is done by our chief guest, Dr. T.P. Jayaraman, President of IAP Kerala. On behalf of the organizing team, I welcome Jayaraman sir for the program. Eminent faculties who will be enlightening us on neonatal sepsis today are Professor Dr. Mangal Bharati from Chennai, Dr. Naveen Jain from Trivandrum, and Dr. Manoj VC from Thrissur. Welcome you all to this academic feast. To felicitate the occasion, we have Dr. Anand Keshavan, past National Vice President, Dr. Joni Sebastian, Secretary IAP Kerala, Dr. Radish Shantakumar, President IAP Thrissur, Dr. Vishnu Mohan, past Secretary of NNF Kerala. Hearty welcome to you all for the program. Dr. Nelbi, Secretary of NNF Kerala, moderators of the session, Dr. Ravindra Verma and Dr. Srijit, other senior members, dignitaries, members of IAP and NNF, a warm welcome to you all for today's scientific program. Once again, welcome you all for today's program. Now, straight away, we will move to presidential address by NNF State President, Dr. T.V. Ravi.
So good evening, ladies and gentlemen. It gives me immense pleasure to kickstart one of the major components of the action plan of NNF Kerala, starting with a topic of paramount significance in clinical practice of neonatology, which is neonatal sepsis, of course. Neonatal sepsis refers to an infection involving bloodstream in the newborn infants less than 28 days old. It continues to remain a leading cause of morbidity and mortality among the infants, especially in the middle and lower income group of babies. It is divided into early onset sepsis, which is also called as EOS, and late onset sepsis, which is called LOS, based on the age of presentation after birth. So neonatal sepsis may be categorized as early onset, which is from day 0 to day 3, or late onset, which is from day 4 and beyond. Of newborns with early onset sepsis, 85% present within 24 hours of life. The median age of onset being 6 hours. 5% present within 24 to 48 hours, and the smaller percentage present within 48 to 72 hours of life. Onset is most rapid in premature neonates. Early onset sepsis is associated with acquisition of microorganisms from the mother. The infections can occur via hematogenesis, transplacental spread from an infected mother, or more commonly via ascending infection from the cervix. In short, neonatal sepsis is the single most common cause of neonatal death in hospital as well as community in developing countries. I'm sure the eminent faculty comprising of Dr. Mangala Bharati, Dr. Naveen Jain, and Dr. V.C. Manoj will throw light on this important topic, by which we will be sharper in our skills to manage such cases. I take this opportunity to solicit wholehearted support of all NNF and IAP members to revamp the MBFHI initiative under the leadership of Dr. T.M. Anandakeshavan, as envisaged by Dr. T.P. Jayaraman, President IAP Kerala, and Dr. Johnny Sebastian, Secretary IAP Kerala. Before I wind up, I humbly request all IAP friends to take NNF membership without any further delay, availing the attractive offers valid for the limited period. I wish you all an academic feast and thank you for the opportunity. Jai NNF, Jai IAP.
Thank you, Ravi sir. Now we will move to introduction of the action plan. I request Dr. Nelby George Matthew, Secretary of NNF2. Over to
Respected seniors and my dear friends, we NNF Kerala is really happy to kickstart this presidential action plan focused CME with every member's support and blessing. Regarding our focused CME program, we focus mainly on 3 aspects of neonatal care. One is sepsis, prematurity, and the asphyxia. As we all know, those are the big killers of newborn, or they are the major causes of morbidity and mortality for the newborn. And also we will take care of transport part because nowadays that is one area which we are lacking. A baby had to reach a higher center safe. These 4 aspects we are taking care of during this focused CME program. That is sepsis, prematurity, asphyxia, as well as transport of the baby. If we can manage these 4 diseases, we can greatly reduce neonatal morbidity as well as mortality. And this focused CME will be focusing on practicing pediatricians as well as those who take care of level 1 as well as level 2 NICUs. That is, this will be more focused on practical aspects. what all you need to do rather than going for high-fi things, basic care of newborn. And this program will be spanning over 12 months. We plan for one CME every month regarding the practical aspects. That is our plan for next 12 months. Hope we will together make this plan a success. Thank you. Thank you all.
Thank you, Nelvi. Now it's the time for inauguration. I request President of IAP Kerala, Dr. T.P. Jayaraman, to inaugurate the session and inaugural address. Over to Jayaraman, sir.
Good evening, everybody. Respected President of NNF, Dr. Rajagopalan, President NNF Kerala, Dr. T.V. Ravi, Secretary NNF Kerala, Dr. Nelby, Secretary Indian Academy of Pediatrics Kerala State, Dr. Johnny Sebastian, Dr. Ananda Keshavan, Dr. Deti Shantakumar, President of IAP Trichur, Dr. Vishnu Mohan, Dr. Murali Raj, respected faculties of the day, Dr. Naveen Jain, Dr. Manoj, and Dr. Mangala Bharati, and Dr. Ravindra Verma, Dr. Phoebe Francis, Dr. Srijit, all other dignitaries on the platform. I am very happy to inaugurate this wonderful action plan by Dr. T.V. Ravi and his team on focus CME of pediatricians. And as Dr. Nilbi was elaborating, you have focused on very important topics like neonatal sepsis, immaturity, and asphyxia being three common causes for increased morbidity and mortality among newborns and infants. As you all know, we are trying our level best to maintain our status of single-digit IMR as well as to reduce it further. It goes a long way in preventing neonatal mortality and morbidity, because most of the, I think a very good percentage of infant mortality is contributed during the extended newborn period of due to this prematurity, asphyxia, and sepsis very often. And you have selected the very apt topics. And as Nelby was telling, another important area is neonatal transport. And it is so wonderful that this coincides with the inauguration of the Neo Cradle by NHM and IAP and NNF Calicut on a trial basis from tomorrow. A wonderful scheme which is organized in transporting newborns that is being tomorrow by the district collector at Calicut. And I feel, and you have selected very good aspects of sepsis as the topics for the day, with diagnosis of sepsis and also care of babies with neonatal sepsis at a level 2 care as a topic for focus CME for pediatricians, rather than going to the tertiary level care. So I wish the very best for this program, and I hope your sessions will enlighten pediatricians regarding the use of investigations as well as the positive predictive value of each investigations which we employ in diagnosis of sepsis at the early stage, as well as management in a level 2 setup. Thank you for inviting me to inaugurate for this wonderful action plan. And I wish the very best to NNF Kerala, NNF Trichur, IAP Trichur, and the speakers and the wonderful action plan Mother's Milk. Thank you so much for this opportunity.
Thank you, Jayaraman sir, for inaugurating this wonderful session. Now we will move to felicitations. First, I would like to welcome our past National Vice President, IAP, Dr. Ananda Keshavan. Over to you, sir. Ananda Keshavan.
Good evening, respected NNF President, District President Dr. Rajagopal, State President Dr. Devi sir, Secretary NLB, Past President Manoj, Dr. Vishnu, Dr. Jayaraman sir, Dr. M. N. Venkatesan, Dr. Murali, Dr. Verma, Nidhi Shantakumar, other dear friends. So outset, I would like to congratulate NNF state branch for organizing a wonderful CME on focused topic like neonatal sepsis like that. I think in future also they will come with more and more topics that may be useful for the practicing pediatrician, especially for the level 2 care. I also would like to thank the entire NNF team for their full heart support for the MBFHA program, which we are going to certify by August 1st. So once again, I thank the full support from NNF team, and also I wish the program all the best. Jai Hind, IAP.
Thank you, Anandakeshavan sir. Now I request Dr. Joni Sebastian, Secretary of IAP, to address the gathering.
Good evening, all. Am I audible?
Yes.
Respected Chair, Dr. TV Ravi sir, President NNF Kerala, IAP Kerala President and my leader Jayaraman sir, other dignitaries on this platform, teachers, seniors and dear colleagues. At the outset, I would like to congratulate Team NNF Kerala and NNF Trichur for arranging this excellent webinar today with a galaxy of experts to enlighten us on a very useful topic for the practicing pediatricians. I feel that the level 2 management of newborns and the newborn care is very important for reducing the mortality as well as the morbidity in the neonatal period. So I wish this webinar all success, and also this series of focused CMEs all success. Thank you. Jai Hind, Jai IAP.
Thank you, Dr. Joni. Now I request Dr. Reddy Shantakumar, IAP President, to address the gathering.
Good evening, all. Respected President Kerala State, Dr. TV Ravi, Dr. Raj Gopal, NNF President Thrissur, Dr. TP Jayaraman, IAP Kerala State President, Dr. Nelby, Secretary, NNF, and all senior IAP members. Thrissur IAP is indeed proud and privileged to be associated with the NNF Forum for all its activities. The success of the recent international Learn from the Legends is a glowing example of our wonderful collaboration. We all await today to hear the CME on neonatal sepsis. I for one, are now with the new developments, I'm always scared when I see a small baby and wonder what are the new insights into the subject. So we all eagerly await to hear it. Wishing the CME all success. Thank you.
Thank you, Dr. Reddy. Now I request past Secretary of NNF Kerala, Dr. Vishnu Mohan, to address. Dr. Vishnu.
Respected President Ravi sir, Jayaraman sir, President IAP Kerala, seniors and my dear friends, a very good evening. A big congratulations and thanks to Ravi sir and LV and team for the wonderful action plan Mother's Milk, and also including this focused training program as a part of the action plan. And I'm sure this will go a long way in improving the quality of neonatal care in our state. And also thanks to our dear team at Thrissur for hosting the inaugural session of the program. And as Ravi sir was mentioning, I reiterate and request all the delegates who have joined NNF to take membership as a part of the membership drive, which is going to close in a few days. So with this, I wish the very best for the action plan as well as today's CME. Thank you.
Thank you, Dr. Vishnu. Now I request Dr. Murali Raj, Coordinator of Focus CME and Treasurer of NNF Kerala, to propose vote of thanks. Over to Murali.
Thank you, Rajagopalan sir. Respected seniors, academicians, and my dear friends, we are coming to the end of the inaugural ceremony. The responsibility assigned to me is to give the vote of thanks. On behalf of the National Neonatology Forum Kerala chapter, I thank Dr. TP Jayaraman sir for his valuable time to inaugurate this prestigious NNF action plan, President Action Plan of Focus to CME. Thank you, sir. I would like to thank Dr. Joni Sebastian, Secretary of IAP Kerala, for giving the felicitations. Now, I would like to thank the Thrissur Neonatology Forum for consenting to conduct this first ever session of focused CME on neonatal sepsis. Thank you, Rajagopal sir, Pawan and Manjusha, for your cooperation and the excellent conductance of this program. Now, I would like to thank my own leader, Dr. Ravi sir, and also Nelby for the excellent arrangement of this program and also the arranging the faculties. And now we are going to hear from three eminent speakers of the country, Dr. V.C. Manoj, Dr. Naveen Jain, and Dr. Mangala Bharati. So thank you all, and wish you all a very happy learning experience. Good evening.
Thank you, Dr. Murali. Now the official inaugural ceremony is over. Now we will move to the main session of the program. I request the moderators, Dr. Ravindra Verma and Dr. Srijit, to take over the session. Over to Verma and Srijit.
Thank you, Dr. Rajagopal. It is extremely kind of you, the organizers of Thrissur Neonatology Forum, for asking me and Srijit to moderate this session. As you all know, a focus CME is very important as far as general pediatrician is concerned, and moreover to the people who are working in a level 2 care. To make it more interesting, we have got a new format. We have one lecture followed by a dialogue, which will enlighten us more on the sepsis as in neonatal period. As you all know, sepsis is a major cause for neonatal mortality, and early identification of sepsis is very crucial in having a very good outcome. To have the first lecture, we have none other than Dr. Naveen Jain, and I hope he has reached home and he is ready. Naveen, you are ready?
Send this presentation.
Okay, fine. To introduce the speaker, I request Febi to introduce Dr. Naveen. Febi, please.
Good evening, respected seniors and friends. Dr. Naveen Jain is a renowned neonatologist across the country and a well-known academician. Sir is particularly recognized for his scholarship in this field and his lucid style of explaining complicated topics. He is the person behind our latest Guwahati and Stats Manual of Neonatology, South Asian edition, and the editor of Illingworth, Development of Infant and Young Child, which are the classic references of any practitioner or a student of this field. He is currently Associate Editor of the journal BMJ, Open Quality South Asian Edition, and member editorial board for several other journals. He is a mentor and a motivational guru for many young budding neonatologists like me. It is my pleasure to invite Naveen Jain sir to discuss his views on diagnosis of sepsis. Over to you, sir.
Thank you, Febi. Before we begin, let me ask all of you to ask your questions in the chat box. We will take the questions after the first session, and then we will go into the dialogue. Thank you. So, Naveen, please.
Dr. Naveen is very much present here, but to avoid the technical glitch because of the connectivity, he has shared his, he has just recorded and sent his video. I'll play it from here. Before, I request all of you to kindly disable the videos so that only the speaker will be heard. Kindly disable your videos until the question answer session comes. Then you please feel free to enable your videos again.
Good evening, friends. Neonatal sepsis is a topic that each one of us deals with every day. Probably one of those conditions where a decision can change a baby's life, either in terms of long-term morbidity or even death. Although a lot of outcomes are decided by supportive care, the crux of all management still remains the antibiotic decision. Let us start with a real-life scenario that we faced yesterday. A preterm birth happened at 34 weeks. The mother had been in labor for 26 hours with rupture of membranes. She had persistent tachycardia at 110 and a CRP of 37. So the obstetric unit induced the pregnancy and decided not to remain conservative because there was a risk of infection to the baby. Fortunately, the baby was completely asymptomatic at birth, required no resuscitation. All the same, the baby was shifted to the newborn unit for observation in view of prematurity. The question that arises now is, should we start antibiotics? Because some of my colleagues felt that they have seen babies who lived well at birth, but over the next few hours progressed to develop severe illness when antibiotics were not started, develop a severe pneumonia, a meningitis, a septic arthritis, and there is clear evidence that in neonatal sepsis, the timing of the first dose of antibiotics is a major determinant of survival. All the same, a very large number of babies who are born with mother having risk factors to transfer infection do not actually infect the baby. Out of 1,000, as many as only 4 or 5 babies will have true infection if they are completely asymptomatic. So should we wait and not give antibiotics to these babies? If it were for a grandma or an IT professional to take a decision, they would have felt very uncomfortable. A grandma would say, antibiotics to such a small baby? Veno. Yeah, antibiotic കഴിക്കുമ്പോൾ എൻ്റെ വയർ upset ആവും. I become very disturbed. All of us have experienced some change in health. We have discussed babies having late onset sepsis, fungal infections, and change of microbiota, which changes everything in the baby's health. Not still discussing the risk of resistance by overuse of antibiotics. So how can we take a decision whether to withhold antibiotics or start antibiotics in a baby who is having very little or no symptoms but at risk of infection? We have many options that we exercise every day. We will send a blood culture, but the result wouldn't be available. Even in the fastest of backtech systems, at least 6 to 8 hours may elapse before we get. And many of us do not trust a negative culture as a reason enough to not wait. This is a fact. In fact, because of the lack of trust on blood culture, the reality is that 80% pediatricians do not send a proper blood culture or do not even wait to see the report. The most incorrectly used lab test at the time of suspicion of an infection is CRP. I haven't forgotten a CRP story 15 years back that changed my practice completely. A similar 35 weeks baby had tachypnea, admitted to the unit and started on CPAP. I met the IT father who was very uncomfortable when I suggested that antibiotics may have to be started. He said, "Doctor, are you sure there is infection?" I said, "No, we are not, but we are planning to do a CRP test. And this will help us to know." He became a little happy. He said, "If the CRP is negative, then you would stop antibiotics." I remained silent for some time. And I said, "No, we will still wait for the culture. And if the baby remains sick still, I would still continue antibiotics." He said, "Doctor, but then why are you doing a CRP? If your decision to treat is going to continue based on symptoms or cultures, and the CRP is not going to change your decision, then why are you doing this test? My mind immediately went back to my basic teaching of research methods by my teacher, Dr. Saurabh from PGI, who said that if you do a test, the decision should be different if the results are different. And if the decisions are same, the test is not useful. So we do not do CRP at all at the time of making decisions whether a baby should be initiated on antibiotics or not. A CBC may be useful, especially in a sick baby. You may find a thrombocytopenia which will warrant treatment, a severe anemia which may be corrected, or a severe neutropenia which may predict severe illness. But what we are doing every day, subconsciously, unknowingly, is using many risk factors, general condition of the baby, social settings, presence of tubes and lines. Many such decision support systems are being used to see. Let us look at some of the well-tested or decision support systems that have helped us thinking what to do. One of such is called as a Sepsis Calculator. Any one of you could access this by going to Google and putting Neonatal Sepsis Calculator. This kind of window will pop up. On the left side here, you have the risk of or the lower prevalence of early onset sepsis in your unit. I have presumed that in India we have very high prevalence compared to the Western world. This number can be from 0.1 to 4 per thousand, which means again you can see that the risk of early onset sepsis is not high. 4 per thousand was the highest allowed in this slot. So if out of 1,000 births that are taking place in your hospital, if 100 are getting antibiotics, then surely your overuse is 25 times. You fill in the gestation age to the fine detail of days, maternal fever, rupture of membranes, maternal GBS. We do GBS in our unit, but more important GBS is whether any bug has been identified in the hypervaginal swab or in cultures. And in the setting of these risk factors, has mother received antibiotics to prevent transfer from mother to baby? If it is more than 4 hours, then the risk is low. Then you just press the button calculate, and you can see that out of 1,000, the risk factor that the baby will get infection is 3 out of 1,000 if baby appears well, 40 out of 1,000 if he is equivocally sick, and 150 out of 1,000 if he is seriously ill. Now, what are these parameters of serious illness? Let us see. Clinical illness or mean the baby is having respiratory distress requiring high flow cannula, CPAP or ventilation, perfusion issues requiring inotropes, or having a severe encephalopathy in the form of seizure or a need for resuscitation for a long time, and respiratory distress severe enough to give oxygen for more than 2 hours to maintain saturation of 90%. So in presence of all of these conditions, which I think by common sense or by safety, none of us would require a decision support system. If a baby is on respiratory support, cardiovascular support, severe encephalopathy, does not saturate in the risk factors for infection, we would all start. So this slide is probably not useful. What do we do if baby is mildly sick? What do you mean by mildly sick? He has tachycardia which is lasting for more than 4 hours, tachypnea, temperature instability, or having any 2 signs, not one. Here it is any one sign, having 2 signs, tachycardia and tachypnea, tachycardia and temperature instability or distress. For these two, if there are 2 signs, even 2 hours or more should be enough to make us consider the antibiotic decision. If the clinical signs, only one clinical sign is there and hasn't lasted 4 hours, or 2 signs are there but disappear rapidly in less than 2 hours, probably we should call this a well-appearing baby, and one must consider seriously whether you can wait before you decide to start antibiotics. Which means that if a sick baby is there, we would all start. Baby needs oxygen, needs inotropes, or has encephalopathy. These are called red flag signs. Even in the NICE protocol, you have red flag signs saying that anyone, signs of shock, seizures, need for mechanical ventilation in term baby, or distress in a preterm baby starting or term baby starting 4 hours after birth. That means there is progressive illness. Even if one sign is there, you start antibiotic. And then we are having 2 risk factors. That is any of the risk factor clinical setting or a clinical pointer. Any of these, one of these or 2 risk factors, 2 clinical signs should prompt a decision to antibiotics. That is rupture of membranes, like in the case we discussed, and a preterm birth, 34 weeks. So probably these 2 are enough to make a decision. And rupture of membranes more than 24 hours already we had in our case. Maternal tachycardia are pointing to chorionitis. So in our case, probably the decision to start will be there even if baby is asymptomatic as per NICE guidelines. So recapping what we said, that if there are persistent signs lasting for more than 4 hours, or a combination of signs or risk factors, 2 of them, then you're more likely to select a group which is going to benefit with antibiotics and overuse can be reduced. But if you're going to start antibiotics with just one clinical sign, which has lasted for a short time, the overuse would be 20 to 30 times. CBC may be helpful, like we discussed, low platelets, low hemoglobin and low NC. And there is no need for a CRP at the start of antibiotics. We remember the scenario we talked about where the father asked that if a baby has a respiratory distress, not going away for 4 hours, and his CRP is negative, would you withhold antibiotics? The answer is no. And this is biologically proven that CRP is elevated late in the course of illness, maybe beyond 24 hours in many cases, and therefore is not a sensitive sign for start of antibiotics. Which antibiotic? We have probably looked at an Indian scenario and did a randomized trial about 8 years back, 10 years back maybe, and we compared amikacin and piperacillin tazobactam head to head as the first antibiotic in both early onset and late onset sepsis settings, and they were equally good. Amikacin is a good broad spectrum antibiotic and remains our first choice. Occasionally our colleagues add amikacin, if ampicillin, if they think the baby is very seriously sick. With the fear of GBS, we had 2 GBS deaths in last 20 years in term babies. And sometimes cefotaxime to babies encephalopathic or shocky, thinking that meningitis cannot be excluded. But in all other cases, our first choice is amikacin, both in early onset and late onset sepsis. A clear message should be that cefotaxime is not a good choice as an empirical antibiotic. I know that when we were residents, we were using Ampigenta or Cefugenta for every baby who was sick due to any illness, hypoglycemia, asphyxia, seizure, high jaundice, everything used to get these antibiotics. Both these antibiotics cause more harm. They increase the risk of late onset sepsis, that is sepsis later on. Fungal infections and NEC and death rates are also higher. And therefore, clearly, these should not be included in the empirical antibiotic list. The Ampigenta that has been continuously part of all guidelines. Interestingly, most Indian guidelines talk about which is the most sensitive antibiotic and have shown that ampicillin and gentamicin were not able to clear more than 3% of even early onset infections, leave alone late onset. In the National Neonatal Parental Database, in the recent Dennis trial that was published from Delhi, a prospective trial which registered all culture positive infections. All of them have shown Ampigenta to miserably fail, and I wonder why they should be recommended as the first line of antibiotic. When should I change maybe if the baby is worsening, surely, or seriously ill, and I would recommend to wait only for 24 hours before deciding whether to upgrade or not 48 hours, if your baby is seriously ill or worsening despite antibiotics. This is an equally difficult decision because we might have started antibiotics merely for two risk factors, rupture of membranes and prematurity, or some symptoms like tachypnea not going away for 6 hours. And now, after a day or two, the baby looks quite well, he's breastfeeding. Do I need to continue antibiotics? 48 hours would be a good time. If you have sent cultures, it would come by now, and a negative culture should be reasonably sure in a non-sick baby. If not, if the baby is just asymptomatic and was started only, or mildly symptomatic and started for only risk factors, probably one must stop antibiotics. And one way to go is to chart antibiotics as only for 48 hours, what is called stop orders. After which, if the team thinks it is necessary, they must restart antibiotics and prescribe once again, so that by default, even if they forget to discuss, the nurse would stop antibiotics after 48 hours. Should we do a CRP before stopping? I have to confess that sometimes my colleagues request for a CRP, and we do it occasionally. Maybe out of 100 decisions to stop, 10 or 12 decisions would happen only after CRP has been done. But personally, I do not feel comfortable. And many publications have shown, both from NICE in UK and from Singapore, more lumbar punctures and so on. And therefore, a clinical decision would be that you must be able to stop antibiotics without support. Again, even in culture hospitals, a shorter course of 7 days must be agreed upon, except if there is meningitis, bone and joint infections, abscess, or stamp warriors, or the baby continues to be critically ill. Except in these situations, a shorter course of 7 days is enough, and the ritualistic 14 days. So what are the suggested practices?
Not heard. Manoj, there is something wrong with the audio, it seems.
I'm sorry, Naveen sir, to interrupt. We can't hear you.
It is not Naveen, actually, it is a recorded video. Manoj, can you just have a look at the audio part of it, please? Manoj? Murali?
Ravindran sir, the video continues to play on Trigana. Manoj sir,
Ravindran sir, are you able to hear me?
Yeah. Naveen sir, no?
Yeah.
Yeah, sir.
I can pitch in on the audio if you can see it.
Thing is that
I'll start speaking as the videos play. So
can you go back?
Yeah, that will be better, I think.
Sir, if you want to go back, Manoj sir has to do it. I'll call him.
If there are persistent signs or a culture comes positive, CRP at stop may not be indicated. The 3 decision support systems that I shared, one was the NICE guideline.
Okay.
Other one is the European consensus statement, takes into 2 clinical signs or 2 lab tests. All of them use the same parameters that we have always used in the unit called STOPS, which is sensorium, temperature, oxygenation, perfusion, and sugars. So if there are 2 clinical signs, let us say poor thermal control, hypothermia not getting better, or fever not getting better, poor oxygenation not getting better for 2 hours, 8 o'clock, 9 o'clock, then antibiotic decision is start. Any one sign not getting better for 4 hours, even if all other parameters are okay. Any serious symptom like severe encephalopathy, profound shock requiring inotropes. Even one sign is enough. It need not persist for long enough before you decide to start. At 48 hours, a default decision should be to stop antibiotics. A continue order must be given. That means in the unit, antibiotics would stop at 48 hours if the doctor did not say, I need to continue. And even in culture positive, it should stop by 7th day. There is no role for 14 days antibiotics unless it is meningitis or bone and joint infection. I have to be frank that this is what we practice most often. I don't want to confess how much is most. It may be 50, 60 or 70% because we have 5 consultants. And at any time, it could be as many as 8 to 10 residents. And all of them have a say, a decision-making, a vote to decide whether a particular test should be done or antibiotics should be started or not. And therefore, there would be times when we do not stick to this algorithm completely. In the subsequent session, which Manoj and Mangla Bharti are going to discuss, probably we would hear a lot of questions and answers on the role of PCR, the role of blood culture, and so many other newer lab tests in making decisions like procalcitonin. We'll be happy to share our experiences along the discussion. Thank you for your attention this evening.
Thank you, Naveen. Thank you, Naveen, for that excellent talk. Sorry, audience, that we had some glitches in the audio in between. We have 2 questions. I think we'll take those 2 questions and then answer the rest of the questions when it comes along at the end of the talk. Srijit, can you ask those 2 questions, please?
So thank you, sir, for the opportunity. And the first question was from Dr. Nandaguma. And the question was, sir, can you elaborate on the low platelets and low ANC values?
Yeah, low platelets are of added clinical value. That means if you do find low platelets, you would add to the treatment supportive care. And it is a very important thing that if you do not find low platelets, it does not rule out infection. But in the presence of low platelets, your suspicion might increase. Similarly, if you find low ANC, then the predictive value of this is reasonably good. That if it may be a serious infection and may suggest an infection, but there could be a lot of infected babies who may not show either high or low ANC at any time. But one thing we need to understand, because we practice pediatrics most of the time, is that high total count is not indicative of infection. Any stress that the baby may present with, anything, just that the baby has a fever due to a viral infection, a vaccination done, a baby is crying for a long time due to unrelated reason, all these things can cause a leukocyte count to be very high. And that was the reason for stating the word as low leukocyte count.
So the next question is, how early we can do a CBC count?
Generally speaking, the CBC count is age related in the first 24 hours of life. So in the first 6 hours of life, the normative values are very, very variable and continuously increasing, and plateau somewhere between 6 to 24 hours of life, both in term and preterm babies. And that is why the NICE guideline, the European guidelines, are very, very clear on this, that if you were going to do a CBC, it should not be done in the first 6 hours of life. If it is a late onset sepsis, of course, you can always do it at the start of illness to be able to support other treatments like thrombocytopenia.
So is it necessary to do a sepsis screen for all low birth weight babies at 24 and 48 hours, even if baby is okay?
No, we don't do sepsis screens even when we think baby is not okay, to be very honest. It is waste of money and blood. And sepsis screen should be done only if you think a baby is not looking well and you don't want to give antibiotics. So a baby is looking well and you have done any test, you call it a sepsis screen like CRP, CBC, any test. But you must promise yourself that if the test comes negative, I have the courage not to start antibiotics. If you have made a decision to start antibiotics based on the clinical setting or the baby's sickness, then the sepsis screen has absolutely zero value in clinical care.
So next question is if there is any significance of doing a CRP at admission to prognosticate for late onset sepsis?
No, I think we just discussed that in that case scenario, that since CRP tends to rise late, there could be a baby who is infected and still has a normal CRP. Similarly, in the early onset sepsis settings, even vaginal delivery can cause CRP to be high. So if you're looking at CRP in the first 24 hours, probably taking a higher cutoff like 15 to 20 may be more useful, but we would not even do the test at that time. If we think clinical setting is there in the form of one risk factor and one clinical sign, or two clinical signs, or a persistent clinical sign, then the baby warrants antibiotic use till cultures are available. A CRP done at the end of 48 hours is used by some in babies who are still having RDS, like setting on ventilator. So you can't differentiate whether it's a pneumonia or RDS, and a negative CRP may give you courage to stop. But if the baby is asymptomatic, then there is no need to do CRP. You can just stop antibiotics after 48 hours.
Okay, sir. The next two questions is regarding amikacin. Our annotations are said it's a very good message to start amikacin as a single drug. And again, but sir, do you check the drug levels for amikacin because it is ototoxic and nephrotoxic?
No, we don't. Although we have done a study very long back that even 7 days of amikacin can cause slight prolongation in the BERA findings, but they are all reversible within a few days. And if you're using the right dose, and the right dose I think I should have discussed is to use it once a day and at 15 milligram per kg. So if you use it in the right dose once a day, then the peak levels are very high, and which is effective in treatment. And the trough levels are low, and that is the one which is associated with toxicity. So one must use, instead of using 7.5 milligram BD, one must use 15 milligram once a day. This will reduce the toxicity of amikacin.
Okay.
So regarding this, Sujit, amikacin, that's a very good message. I mean, how many units are using amikacin alone?
After when we started initially about 20 years back, there was a lot of concern that we may be missing out GBS, and then we did this trial where RCT where we compared amikacin versus piptas. Following this, Hyderabad Srinivas Murthy's unit uses the same, and then St. John's published a paper and they also did a trial on the same thing, and they have also adopted one amikacin monotherapy. And we had David Isaacs, who was visiting India at that time about 8 years back, who is a world authority on pediatric infections. And he was initially very skeptical, but then after going through the data, he also felt that this is the choice. If you look at mathematical model of Dr. Divakar's paper, which was published very long back, 10 years back, on what are the bugs which are growing from Kerala, you can see that amikacin worked in 80%. Those days, ciprofloxacin worked in about 70%, and but it is little less now. But ampicillin was 5%. So what are we doing? But the side effects of ampicillin are very high. Similarly, cefotaxime also is only about 10 to 20%. And one of the reasons is that this cost of cefotaxime is cheaper than the cost of the syringe itself. And therefore, overuse of cefotaxime is very high in every setting. And it causes both fungal sepsis as well as resistance. So one must not use cefotaxime and ampicillin unless you have a specific indication like meningitis or GBS-like setting.
Thank you, Dr. Naveen. I think we have a long another session go now with the dialogue between Manoj and Dr. Mangala Bharati. I think we will take the rest of the questions at the end of the dialogue session. Thank you, Naveen. If you are here, please join us throughout the session. Thank you.
Sir. Thank you.
Now, I invite Dr. Manjusha to introduce Dr. Mangala Bharati and Dr. Manoj.
It's a great privilege to introduce two great speakers and two great teachers of neonatology in today's session. So today we are having a very special session, a dialogue presentation between Dr. VC Manoj, sir is the head of Department of Neonatology at Jubilee Mission Medical College, Thrissur. Sorry, let me just put it in slideshow mode. Sir, head of the Department of Neonatology at Jubilee Mission Medical College, Thrissur. Sir is a excellent teacher, an academician, and he's published various papers in international and national journals, and is an author and co-author of various books in neonatology. He's also the State Academic Coordinator for Advanced NRP and a teacher and research guide for the IAP and NNF Postdoctoral Neonatal Fellowships. He's a National Executive Member of NNF India and the Executive Member of South Zone of the Neonatology Chapter of IAP. He has served as the President of NNF for the previous year and the President of NNF and the President of NNF IAP Thrissur. I welcome you, sir, to this session. Next, I would like to invite and introduce to you Mangal Bharti, sir. Sir needs no introduction. Currently, he is a professor of neonatology at the Department of Neonatology, Madras Medical College, Chennai. He is also the head of Excellence for Newborn at the Institute of Obstetrics and Gynecology, EGMOR, and the head of academics and consultant neonatology at Mehta's Hospital, Chennai. Sir is an avid speaker, researcher, and academician. He is and the principal investigator in many trials. He's involved in the development of medical devices and also has various publications in both national and international journals. It's an honor to have you, sir, here today in our session. Over to the moderator.
Srijit, you can.
Shall we start?
I think we will start. Manoj, please start the session.
Yes, it's already 8:30. We'll start.
Yeah. Okay. Thank you. So, good evening, everyone. It's again a proud privilege to talk among friends. We will now have a dialogue between me and a close friend of mine, Professor Mangala Bharati from Chennai. We hope to have some discussions at the end as well. Being the host, let me begin. First, let us talk about babies at risk for neonatal sepsis. We had an excellent talk by Naveen. He stressed on the need to avoid antibiotics whenever possible. He told us how and when to start antibiotics and when to stop. Just before we proceed further, let me just retrace some of the key points that we will start from. He told us CRP can only help in ruling in sepsis, or rather CRP cannot help us in ruling out sepsis. So it cannot be a test to just start your to base your decision on starting antibiotics. And if you start empirically, you need to make up your mind and then stop as early as possible, at least within the first 48 hours. Now let us elaborate this further. So just consider a scenario. Mother is rushed to labor room with leaking membranes for 28 hours. The common scenario you and me face. Now 28 hours means now it qualifies the criteria for at least some of us to just jump into start antibiotics. Now there is a distinction between the rupture of membrane, the premature rupture of membrane, preterm premature rupture of membrane. That's more for academic purpose, but then still we'll just reiterate those. So we call it a premature rupture of membrane when the leaking has happened before the onset of labor, and then preterm premature, of course, when the fetus that is going to be delivered is a preterm. And we all know the basic classification which we should guide our decision. Newborns are not a single group of babies, they are a heterogeneous group consisting of a variety of population. Just like you would not like to start the same treatment for a child and an adult for the same illness, you would not like to start treatment for each group of neonates. You have the term babies. Now the term babies, the classical term babies itself, we say the early term and term. Early term in the 37 and 38 weeks, and the actual term is only 39 and 40 weeks. And you have the intermediate zone, the late preterm babies who are neither preterm nor have they mature enough to be called term. They are the 34, 35, 36 weeks period of gestation babies, and the genuine preterm babies who are 33 weeks and below. Even the preterm babies, you have the extreme preterm babies when they are below 28 weeks who are a different group altogether. Then you have the very preterm babies between 31 weeks and 28 weeks, and then the 32, 33 weeks are your moderate preterm baby. So this is a broad classification. So when you are dealing with a baby, you have to look at which is the group of baby that I am dealing with. Now, Mangala, let's start our hearty welcome, Mangala. Thank you for joining us.
Hello, good evening, everyone. Hope I'm audible.
Yeah, you are.
Awesome. Thank you, sir. At the outset, my respect and sincere thanks to NNF and IAP Kerala, Manu sir, and all the office bearers. We just heard an excellent, very crystal clear and comprehensive lecture from our senior and mentor, Naveen sir. So almost I think all the points have been clearly made, and he makes the points so clear. It's always, it's not easy to, even though it's a discussion that we can follow. I think this is more of a little bit discussing the details of what Naveen sir has already told us. And I saw some messages, I think in the chat box, people are asking for some slides or a PowerPoint. I just want to give you a good news. Just don't worry, there are no prepared slides here. This is just a casual talk between two people, and you can also, you're welcome to step in. So as it is just a dialogue, so we didn't want to bring in what to say, a theory or evidence, things like that, because sepsis is a very common topic that a common situation we all face in our day-to-day clinical practice. So we'll be more discussing about the concepts around, so even though we may be using some questions to just carry on the discussion. So I think we'll be hanging on more to, so what are the scenarios that we face, likely scenarios, and how do we approach them? And we'll like to be more honest, like rather than just citing a theory or what is said in the literature. So we may discuss that, but we'll try to conclude by really saying that how much we do, or so because each one of our setting is different. So I am from a public setting background primarily. I'm in a medical college hospital, which caters to around 17,000-18,000 deliveries per year. And we know again the burden of sepsis and the mortality associated with sepsis is quite different. So we do have a very, very significant burden. So and we are not able to match the standards of the private setting where we can control things in a better way. So the approaches can be different. That's what a dialogue is all about, and to have various perspectives. So Manu sir just asked me, he said that, okay, so you have a, say a mother with risk factors. The risk factor here was this for premature rupture of membranes, and it was a long duration also. So we all know, so what is considered long duration? Say, so anywhere, whenever the rupture of membranes, say, is more than 18 hours, the duration of rupture of membranes in general. Though this number is not a very, what to say, everyone may not agree on the same number, okay? But okay, in general, so most people agree that if the duration of membranes is more than 18 hours, it's considered a risk factor for sepsis. And he just told us there is the difference between PROM and the rupture of membranes. PROM is a premature rupture. It has nothing to do with the duration, whereas the duration of rupture of membranes is calculated in terms of hours. So how do we approach a baby who is born to a mother with risk factors? We know there are many risk factors. Say the common ones are what? The mother can have fever, her WBC counts can show higher counts, leukocytosis in the mother. Just a spontaneous onset of preterm labor can be a risk factor for him, because we don't know, because it may be the infection that has triggered the preterm onset of labor. And there may be situations where there are like foul smelling discharges. And also to some extent, what to say, the obstetric practices like number of vaginal examinations done, or the labor was induced. We know that people use methods like Foley's, artificial rupture of membranes, these interventions which are done to induce labor in certain situations. So there are many risk factors. So number one point that I would like to make here is that even though we are talking about many risk factors, Sir, why he has asked me about, he has asked me 3 different scenarios. So like a term baby.
We will, for since it's basically for level 2 care, let us at least discuss 3 scenarios: 30 weeks gestation, 35 weeks, and 39 weeks. Suppose the same thing happens. How are you going to investigate? And first question is, how are you going to investigate an asymptomatic baby?
So I'm just coming to the same point exactly. So there may be risk factors, but if you just ask me what are the single most important risk factor as far as the possibility of a baby developing an infection from the mother is concerned, that is the gestational age and the birth weight. So all these studies, a lot of studies, even though we have listed so many risk factors, the most important risk factor is the gestational age and birth weight. So what I'm trying to, or we are trying to say here is that, see, the presence of risk factors, whether it causes sepsis or not, it is not linear. It is not the same. That means higher the gestation, especially if a baby is a term baby. So even though there are risk factors in the mothers, the possibility of transmission is very, very low. As we come down, so from 35 weeks onwards, below 35 weeks onwards, and more we move towards the so-called VLBWs, where the gestation is something like less than 32 weeks or less than 1,500, there is a disproportionate increase in the risk of sepsis. So that's why, at least the first one will say, in a term baby, if you think that even though there are some risk factors in the mother, you can, people are taking various approaches. Like, what are the options available to us? The number one, just start, don't take risk, take cultures and start antibiotics if there are risk factors. And there could be a in-between approach where, okay, you try to assess the risk by doing some scoring systems. And then you try to classify like who is at a higher risk and who is at a lower risk. Then you have maybe, if there is a higher risk, you may start antibiotics or you may start investigating. Or if it is a lower risk, you may like to hold on and see. The third option, okay, just let me see, let me keep observing the baby. I can't just send this baby to the mother, but let me just only look for clinical signs. I won't do anything else. I'll try to assess the risk and all. So just see, observe the baby repeatedly over the, say, first 12 hours, most important hours, if the baby is developing any symptom. If he's not developing symptoms in the first 12 hours, it's very unlikely this fellow is going to become symptomatic. He's not infected. So I don't need to do anything much about this baby. If you want to, so out of these 3 approaches are, we usually follow in a term baby with risk factors, even though there are some risk factors. So we just try to follow, rather than trying to quantify the risk, we take the approach of closely, if the baby is asymptomatic at birth, did not require any resuscitation, baby is fine, we just observe them for a period of 12 hours and see if the baby is developing any symptoms. But that 12 hours observation is mandatory. That baby has to be in a place, we need to have a facility to observe this baby for a period of 12 hours. And if the baby is fine, then it is okay. We don't investigate the baby anymore. On the other end, any VLBW baby or baby is less than 1,500, hardly these babies are asymptomatic. They may have at least some symptom like a mild respiratory distress, at least a tachypnea. So there comes the challenge in this group. So even the sepsis scores are not, we don't find much application of this quantification of risk when we talk about these very small babies. So here may be that only in certain situations, like, so you are for sure, you know that this is not an unexplained preterm delivery. And if you think that the mode of delivery has been this, maybe there are situations where the termination of pregnancy happens for maternal indications and there is no premature rupture of membranes. And if the baby is delivered by a cesarean section, not even vaginally, no induction of labor has been done. And there was no indication on the maternal side to start antibiotics, even because they didn't think there is any need for starting intrapartum antibiotics. One small group, only in this small group, I'll say that, okay, I may try to withhold antibiotics. Otherwise, less than 1,500 grams VLBW showing some symptoms, this will be a group where most of the time, as we have to intervene, we'll be taking, always if you have to go into start antibiotics, you have to take cultures, start cultures and start antibiotics, no role for a septic screen. The in-between group, not a VLBW, neither a VLBW, where you just, if it is symptomatic, you straight away start antibiotics, nor a term baby where you just say, okay, fine, we don't need to do anything, just observe. The in-between, 1,500 grams to the 3 kg babies, they are the ones where I think we had Naveen sir showed us a very good sepsis risk calculator. So there are now even improvised approaches to that, the so-called sepsis screen. We know a sepsis screen from a PGI where many factors are included, and there is a standard sepsis screen calculator was devised from the West. So what people have done, they are just bringing out another approach called an integrative approach. Again, that was what was shown by Naveen sir, where we take into consideration the risk factors on one hand, then we just estimate what is the likely risk of a sepsis if there are risk factors. Then we look at the baby also. Is the baby symptomatic? Or even if he is symptomatic, is it a very mild symptom or a plus or minus symptom? Or is he having some symptoms which are highly likely to have sepsis? So combining these two, risk factors plus how the baby looks, then they are coming out some estimates which you can just make use of a calculator, we can make use of, and then take a decision. So either to withhold or take cultures or start antibiotics. So I would like to divide them into these three groups: VLBW, term, and the in-between group. In one line, VLBW with symptoms, and only there will be a small chunk where we have the guts to stop antibiotics. Otherwise, most of the times we'll be taking at least. That doesn't mean that we'll be continuing antibiotics forever in these babies. I'm just talking about the beginning. If there are just risk factors and it's a VLBW, I'll take cultures and start antibiotics. Term baby, I won't even go for risk stratification. Just observe the baby for 12 hours closely. If there are symptoms, evaluate further, think about sepsis, otherwise no need. In between group, that's where all these sepsis calculators, risk assessment, there also don't look only into risk factors, take an integrative approach where you assess the risk factors, do some scoring, also look into the baby, how the baby is, combine these two and make a decision.
Excellent. So it's like stratifying the whole babies into three groups and then decide when you should straight away start, where you just work up, or where you just observe, not even work up. Probably if you are going to do that now, to take this a little bit further, you alluded to this, there is a lot of variation in the practice in our country. So there is a resource limited setting and there is another resource with setting, which are both trying to keep up the standard. So any difference you would suggest between the two groups?
Sir, I do understand that. So we do have a very lot of variations in the resources available. But whatever approach that we are discussing right now, this doesn't, because so what we're saying is that the three strata. So look into one, you just observe. We're not going to do anything. The other one, we are saying that if there are symptoms, if it is a VLBW baby, except in the given scenario, you just take cultures and start antibiotics. And even in the in-between group, we are not talking about any tests here. We are not talking about CRP, CBCs, anything. Just look for risk factors. There are some scores which you can use and assess the baby. Combining these two, all that we do say that be objective here rather than just being a subjective where you just some may think that to start or not start. Bring in some objectivity, make use of these scoring systems, which have shown, the thing is that people have shown that once they start improvising these practices after bringing in these calculators or the sepsis risk score assessments, the number of blood cultures taken and the number of unnecessary exposure to antibiotics have drastically become less. We all know that the ill effects of unnecessary antibiotics, both for, that is there even for term babies. We know it's not only for preterm. So I think this approach can be followed in any setting, whether it is level 1 or level 2. We don't need any special gadgets or investigations to follow this approach.
Great. So the practice should not be different in research limited setting or research setting. Great message to be given. Now, now we are stratified and then we are decided to start antibiotic. A lot of discussion has already taken place on antibiotics. We can continue, but let's look at the other aspects, because we are and basically when you look at sepsis, one of the things which was classically taught was sepsis is basically classified into early onset neonatal sepsis and late onset neonatal sepsis. Now, there is a lot of purpose behind this. Like the original purpose was that the physiologic adaptation, when it is not over, whatever sepsis the baby gets is probably your early neonatal sepsis. So in the first 3 days or first 7 days, whichever way you want to look at it, when actually the cause can be attributed to the mother as well. And the late onset sepsis when the postnatal adaptation is over. Now, let us look at a slightly different angle, a philosophical angle. Mangala, is there any purpose and relevance of this classification today?
I think our standard practice is that actually we, in most of the fields, we follow the Western practices. That's where the evidence starts coming from. And we know well that so it's not always worthwhile or appropriate to just extrapolate or borrow whatever the West says. The concept is very important, because so you just pointed out, sir, the importance of what is the need of a differentiation. So if somebody gets an infection, manifests features of clinical signs or symptoms of an infection within 72 hours, most likely the infection would have come from the perinatal practices, from the maternal genital tract. Whereas if a baby starts showing symptoms after 72 hours, it is most likely occurred from the interventions what we are doing in the NICU or from the environment. So in that sense, definitely this is still very important, because even today, this holds very important, this differential classification as far as the Western world is concerned, because for them, the bugs which come from the mother are a lot different when compared to the bugs that come from the NICU or from the environment. Even their pattern is changing a lot. So we are talking a lot about GBS. So they're all if you look into the prophylaxis, intrapartum, you will hear a lot about GBS. But if you look into the US data, even today, even for US, the number one organisms for early onset neonatal sepsis is not GBS. 50% of their contribution of EONS in US today is coming from E. coli. But they do have, unlike, as Naveen sir said, hardly once in a lifetime you just see, or once in a while, you see a GBS here. But they have around 20% incidence of GBS, the cultures for the EONS. So it is still worthwhile for them, whereas this GBS is not seen, hardly seen in there if the infection happens beyond 72 hours. So the approach differs as far as the etiology is concerned. They want to use a different set of antibiotics because the likely organism may be different if it is the onset is early, and they want to bring in a total different set of organisms if the infection starts later. But what are the Indian scenario? We were also following this approach for quite some time, trying to differentiate. But so wonderful articles, a lot of literature published. We all know what this Delhi study, a very, very good study with a lot of babies from Delhi, around Delhi. So there is a lot of clear evidence available from India to clearly show that as far as our country is concerned, if you look into the bugs which are causing these two kind of infections, whether it is coming from the maternal genital tract or it is coming from the environment, there is no difference in the type of or the distribution of organisms what we see in these two, what we grow in cultures in these two type of infections. Most importantly, even if you look into their antibiotic sensitivity pattern. So is it different in these two? People have not found a difference in their antibiotic sensitivity pattern as well. So for all practical purposes, as far as the choice of an antibiotic is concerned, you are just going to approach these two as the same. So it holds true for us to maybe to understand where the bug would have likely to come from. But as far as the kind of bug which you are likely to deal, doesn't matter differentiating from UONS or LONS, we are just going to approach the same whenever the infection begins in any.
Great. So it basically throws more light into the epidemiological aspects and things like that. From management point of view, it may not much of a difference. But there is a different note which also we should take into consideration. Professor Sridhar Santhanam's group from CMC Vellore had published a path-breaking study regarding the prevalence of GBS. And since then, so the previous concept of GBS is totally non-existent. We still know it doesn't contribute much of our this thing. But the problem with GBS is that GBS is one of the bugs that if you have a GBS sepsis, the presentation can be very, very fast. And the babies deteriorate very fast. And most of the time, if you do not use the perfect culture medium, sheep blood agar, fresh sheep blood agar, which in the COVID times is very difficult to get. So you will not grow anything. So just because you don't grow the bug, we can't say the bug is not there. I am quoting the various evidence from the the Professor Sridhar Santhanam's study, and then plus the other studies that have come up in this scenario. So let us not totally say that GBS is not there, not a problem, especially in a culture negative sepsis. Baby is very sick and you are very convinced that it is sepsis, then probably GBS has to be thought of. But as rightly pointed out, definitely GBS is not our predominant enemy. So monotherapy with amikacin may be justified if you have again your own data which shows that your bugs are not that, and provided your microbiology reports are good, you can believe your cultures and the baby's you don't get too many culture negative sepsis. If you get too many culture negative sepsis, you need to audit. And I would just add to stress on that point again. One more point is that usually what is happening is we have a tendency to blame everything on sepsis. So that also should not happen. Just because you thought it's sepsis, if it is not correlating, it's some other problem. Just because you don't want to say anything, don't blame it as GBS sepsis. GBS sepsis. So probably the message should be that GBS is not at all common in our country, but once in a while you burn your fingers if you do not remember this. And so monotherapy you need to really modify, and we have come to an era of what is called precision medicine, where this whole concept started in oncology. Now it is there in neonatology as well, where to put it in very simple language, the same treatment for the same disease may work differently in two patients. We all know that. This is just a scientific way of saying the same thing. So just to take it to that level, so you cannot just adopt a protocol and say that, okay, I'm going to start only amikacin. Or you cannot say that I will start only Ampigenda. You need to really customize the treatment as per the case. This is just a guideline only. Do you agree, Mangala?
Yeah, sure, sir. I fully agree with you. I am aware of the publications from few units, especially like CMC, where they are reporting GBS. So maybe that I think one of the factors is the very high prevalence of these very bad gram-negative bugs. Maybe they are not allowing GBS to be there. They're taking the upper hand. Maybe once we control these gram-negative infections, which is going to take a long time in India, maybe our patterns might change. Maybe we may start seeing more of GBS later. I'm not sure. This is just a hypothesis.
Great. So now let us go on to, because the time is getting over. So let us go on to another, when you're going to manage these babies, one of the basic questions that you ask yourself, even if you're practicing periphery, should I do an LP or not? Because we all know sepsis is always coexisting with meningitis in the early period. So should I do an LP? So Mangala, can I ask you, when should you do an LP? And okay, first let us see when you should do, then we will take it further. Yes.
I should admit upfront that there is a lot. This is one area where there is a lot of difference between what is taught, what is preached, and what is practically done. I won't find fault with people for not sticking, because we are worried about doing then this invasive procedure, especially in the smallest of babies, more so when they are sick and may have problems like thrombocytopenia. If you look into the classical teaching, or even the recent the CPG guidelines put forward by NNF, the recent revisions also. So because why we are insisting on CSF analysis as far as neonatal sepsis is concerned, we know unlike infections in other age groups, this is an age group where the incidence of meningitis associated with the bloodstream infection is going to be very, very high, because so they don't have that much defense systems preventing the entry of these bugs into the central nervous system. So as the chance of a baby having meningitis is quite high, it is always recommended to keep CSF analysis as a part of something like a package whenever we want to evaluate a baby with sepsis, except in few situations. So that is that even the CPG says only few exceptions, where that means soon after birth, a baby presenting only with a respiratory illness and baby doesn't have any other sign, especially there are no CNS signs or systemic signs. You don't have a baby with shock, you don't have perfusion abnormalities, you don't have lethargy or other abnormalities. You do have only respiratory problems in the baby and you are managing. There are maybe risk factors. You think that this may be HMD, TTN, or this may be even congenital pneumonia. So maybe that is a situation where you need not do an LP. Barring that situations, our NNF CPG guidelines recommend doing CSF analysis in all the other situations. But having said that, they also know that, okay, it is not many times you always have to consider the clinical stability of the patient. We should not be doing a procedure. The most importantly, rather than the technique per se, it is the way we have to bend the baby. So where it may compromise the respiratory system, hemodynamic imbalance can happen. So they also say that, okay, you can postpone or withhold CSF analysis if you think that the baby is not clinically stable and the baby is sick. So bottom message will say neonatal sepsis. So whenever feasible, whenever if you think that a clinical situation permits, you are not dealing with a very sick baby, and if the baby is especially barring a situation of an early onset type, soon after birth, the baby is having only respiratory problems, nothing else. Late onset scenario, or the baby has got systemic signs, or baby has have CNS findings, lethargy, things like that. So please go for an LP, because the validity of the test, the whatever we get out of this test, usually the yield of this test is much low, even if you're doing in an appropriate time. The more you delay the test, hardly that you will get anything out of this test. It won't help you to really differentiate whether the baby has got meningitis or not if you expose the baby to antibiotics for quite some time. So do it early whenever feasible. That will be my pardon, sir.
What if it's a traumatic tap? Most of the time, who does the LP may not be the most senior person. It will be left to the residents or whatever, for whatever reason you told the parents, I am going to do an LP, and then you did and you got a traumatic tap. See, so now how are you going to interpret this?
I think even yesterday, one of my patients, my resident had a traumatic LP, and he told me the next morning, sir, the LP was traumatic yesterday. So what I asked him, what you did? So he said, sir, I didn't do anything because it's a traumatic, so I can't do anything about it. I just left it there. So this is actually a very important area. The residents often think, many people think that if an LP is what to say, when we say traumatic, we are not talking about a situation where you don't get anything flowing there, where you just got only blood. We are talking about a blood-stained CSF. You are getting a CSF, but it is getting mixed with blood. There is a bloody CSF which is coming out. It is not totally useless, because again, just we are discussing that how invasive this procedure is. So why do you want to unnecessarily expose the baby? We can try our best to get whatever is whatever we can read from this. So people have shown two things are very clear. One thing is that a gram stain and a culture. See, how is it going to get influenced? Gram stain, we're just going to do a stain in that one and see, even if it is coming from blood, you are just going to identify, okay, that organism has to be there in blood of that baby. So please send it for a gram stain, even if it is a traumatic one, and send it for a culture. These two you can do. And again, I think Saurabh sir has shown in a study from PGI, even the sugar values, that's one value which doesn't seem to, we often think that sugar value may get altered whenever the LP is traumatic. But he has shown that compared to other variants like WBCs, they get changed, they get altered a lot. But sugar is one thing. That means if you are going to have a low sugar, what do you mean by low sugar? By I think we are talking about something like less than 25 milligrams. That is that number. I'm not talking about very high numbers. If you're having such a low sugar, even if the LP is traumatic, you have to highly suspect the possibility of meningitis. As far as WBCs and other things, people have proposed many estimations, like you can just do a revised estimate for this much amount of RBC, this many WBCs may there. But those estimates have not been found to be practically helpful. So I'll say I'll use traumatic LP only for these three. I'll send for a gram stain and culture, and I'll look into the sugar. If it is less than 25, even if it is traumatic, I'll be worried that it could be meningitis.
Perfect. Probably we should not be doing the calculations to of the RBC, WBC, and then try to interpret. That doesn't work. So that is right. Actually, it's not totally useful. But the problem is you already counsel the parents that I am going to do an LP, and then you can't say that now. Oh no, I'm sorry. The test did not go properly. We live in an era of defensive medicine, so you need to at least do some tests if that is possible. Now, another area, a doubt which people have is, now you are confirmed meningitis, you started antibiotics. Do you need a repeat LP to stop antibiotics, or can you just presumably give for 14 days, or some people give for 14 days for gram positive bugs and 21 days for gram negative bugs? So, like, what is your take on this?
Again, if you go by the textbooks, where actually the information has been borrowed from the evidence what is there in adults and older children. So it is a standard practice to repeat an LP to see whether your bugs are responding, whether how is the CSF penetration of the antibiotic and what is the response. Then from that point onwards, That means they decide the duration of antibiotics only from the time of response. They do a repeat LP to see whether the response happens or not. So if the response doesn't happen, they do an alteration in the treatment. If the response happens, from that point onwards, they decide the duration of the treatment. But this is hardly practiced in neonatology. And I'll say this is not based on any evidence. We don't have any studies available to say that which of the practices is right in the neonates. But as we are worried about, again, the invasiveness of this procedure and the upsets that can happen to the baby, throughout the world, as far as my knowledge goes, we don't go for a repeat culture. The standard, we may be doing a repeat culture in a different scenario, where you think the baby is getting more sick. That means the baby is not showing clinical improvement. If there is no clinical improvement, baby, something like baby continues to be encephalopathic despite you starting treatment, even after around say 40 to 78 hours, or a baby starts throwing seizures again. So you think that this baby is surely not responding and the baby is worsening. That's the time maybe if you're worried, if you're not sure whether it is because of the meningitis not responding, again, I'll say it's a very, very rare scenario. So I personally don't go for repeat LPs as far as neonatal meningitis is concerned.
Excellent. So this is again a gray area, but probably the advice is not to go for a repeat one. But there is some gray area left here. So we had covered most of the antibiotic issues, actually some of them that will never end. But then do you really alter your antibiotics after the LP report has come in? You started the baby on say amikacin or CP gentamicin or whatever is your choice of drug and for the sepsis, and then subsequently your LP is positive. Now what are you going to do? How are you going to alter your antibiotic policy after the LP report has come?
So again, a difficult question, sir. But I think I'll just simply most of the time follow what we do for a blood culture positive sepsis. I would like to take the same approach, because we do often see a lot of difference between what the report says and what is actually happening clinically. That means the so-called difference between in vitro sensitivity and in vivo sensitivity. So whenever we are suspecting meningitis, obviously you will be choosing a drug which is more likely to have which has a good CS of penetration in an uninflamed meninges. We know that most of the antibiotics can cross the meninges once it is inflamed. Even the so-called ones with the poor penetration, CS of penetration, their penetration increases if it is if the inflammation happens. But the problem is that we don't know whether it is for sure. We don't know how long, whether it will be consistent. So we should not make a mistake there. We should first choose an antibiotic whenever we are suspecting meningitis, doing a CSF analysis. We should choose an antibiotic which has got a good CS of penetration. But beyond that point, I will change antibiotics, something like if I have a better drug which is of a lower category and which will still have a good CS of penetration, I may just go for that drug. Otherwise, if just because I do have a bug grown in CSF, and the report is saying that maybe other antibiotics, by its physical properties, if they say this antibiotic may have a good CS of penetration compared to the one what I'm using, I'll just go by my clinical response. If clinically baby is showing a response, I will stick my one. That's what I do in blood culture positive cases also. Do you have a difference of opinion, sir? This is what I do actually.
Perfect. I totally agree with you. I would also like to say one point regarding which was touched upon by Naveen, that is regarding the cephalosporins. Cephalosporins are not a good choice as first line antibiotics, and until you have confirmed meningitis, probably this is one of the drugs that you should avoid using in NICU. This has become a standard practice in some places to use cefotaxime, amikacin as the choice. Cefotaxime or any cephalosporin should not be used in NICU until you have a reason for it. And meningitis may justify its use in select cases. Is it okay? If you say
fine, sir. Perfect.
Perfect. Okay. Now we have talked a lot about antibiotics, and time is already moving, going. So let's talk a little bit about talk a little bit away from antibiotics. The one of the basic concepts when we talk about neonatal sepsis is prevention is better than cure. The moment you land up with sepsis is a dark horse, and you are going to have problems. Whatever. You are going to, this is a dark hole. Whatever you do, what is going to happen is the baby, if it is sick with something else, this is going to give you unexpected outcomes. So we all know that we don't want to get sepsis. So prevention should be the mantra. So we'll talk a little bit about aseptic precautions. What are the Mangala? Now, what are the common do's and don'ts in a level 2 care setting, as far as prevention is concerned, prevention of sepsis is concerned?
So what would be the settings? I think the principles are largely applicable. First, I'd like to start with an early onset sepsis scenario, because the early onset sepsis, we do still lose a lot of babies because of this early onset sepsis. First, we need to understand that, again, there's no point in just blaming that this infection is coming from the labor room or from the mother. So it is our responsibility to just work closely with our obstetricians, however difficult it may be. So we do insist on, because I don't see much of emphasis happening in many of the even teaching hospitals on intrapartum antibiotics can compare to interventions like antenatal corticosteroids. A lot of importance is given. People look into the data. What is the coverage of antenatal corticosteroids happening to the mother? Even they go and talk about Maxelf, giving Maxelf to the mother, but hardly we are looking into really how many mothers with risk factors for what is sepsis, especially when it can be when it is a risk factor for the neonate, are treated adequately with proper intrapartum antibiotics. Because I think that may not we may not find fault with them. We also do the same in many things. I do find a lot of people still stuck with even giving oral antibiotics or a drug like erythromycin only for intrapartum antibiotic prophylaxis, even if there is PROM. So it's high time that we just start working with them. So again, only two areas I'll say that, okay, the intrapartum practices, I think they will know better. Number of examinations done, how a labor is getting induced, the sepsis around those interventions. Second important thing, please talk to them about intrapartum antibiotics. Have a discussion. We do, whether they're doing or not, in my institution, we always do a monthly audit of, we try to do an audit of this high vaginal swabs that have been sent, what the organism is grown, what are the likely sensitivity that is happening. So, and then we like to suggest our choices for intrapartum antibiotics, which is an ongoing discussion happening. That might be a good point to start. So this is about sir.
Please,
and
please continue.
Sir, you want to say something, sir? Please, I'll wait for your answer.
No. Continue. I think we will continue giving the precise summary, and already time is up. Continue, please.
Okay, I'll make the second component. I'll quick and fast. I think this is all known to everyone. So what we have to do to prevent late onset sepsis, especially nosocomial sepsis happening there. To start with the do's, the list is endless. I just want to emphasize only the very important and the basic points which can be done in any setting. First and foremost, so we don't need to, as far as possible, don't separate the baby from the mother. And don't, please work a lot on skin-to-skin contact, early introduction of feeds and breastfeeds. Early introduction of feeds and breastfeeds, skin-to-skin contact, all these are possible only if we allow the mother or motivate the mother to come into our unit. If a mother is not available, please allow other family members. And many of us, I think, about some units still, even though there is a lot of change in practice, there is a belief in certain areas where we think that we should not allow anybody into the unit. We should keep the unit sterile. Only if we do that, the babies, we are protecting the babies from developing sepsis. I think, I would like to vote for saying that the infection is not coming from the attender or somebody. It is coming from our nurses, the doctors, the residents. It is all, they're all cross infections. We are the bad people who are bringing infections to all these babies. Hardly, I'm not saying it's zero, but at least even if it is happening, it can happen only to that baby. They are not touching any other baby. We are the ones moving, we are moving from one person to the other person. So involve the family, involve the mother, early initiation of breastfeed, skin-to-skin contact. Whenever we have to do procedures, we all know, I think still the bottom line is all about hand hygiene. We repeatedly talk about hand washing and hand hygiene, but we often or seldom spend time in bringing in any system change or a behavioral modification. Rather than just, it doesn't help. Pulling somebody every now and then, or just keep on teaching what are the techniques, 6 steps of hand washing. I don't think the problem is there. We need to understand why actually, even though people know that they have to wash their hands, they know they have to use hand rubs, but it's not getting implemented. We're all humans. So where is the problem? How can we bring in a system change, or how can we bring in some objective behavioral changes which can help in improving? You can make it 100%, but you can always move from 30, 40, 50, and 60. That is one area where you need to always focus on. And if your resources permit, I would like to invest in separating septic or sick babies from the well babies. So all may not have the enough infrastructure to do that. But I was struggling for nearly a year or two, but I am now able to establish. In fact, actually, the number of babies in my septic NICU is sometimes more than the number of babies in the clean side. But that happens in public settings. We do have so many babies with risk factors and sick babies, but still, at least this cross-infection rate is coming out a lot. We don't encounter a situation where one baby will become sick. The next day, the babies around will start, around the baby will all start becoming sick one by one. That is a very bad, that babies would have been stable, they would have been growing babies, will be unnecessarily getting into these problems. So cohorting, if you have facilities, please try at least to achieve cohorting, separating, because this is just a big barrier to prevent a cross-infection. Because especially in public settings, we cannot have separate manpower, we can't totally have two different people taking care of a sick baby and a stable baby. Nurse-patient ratios cannot be maintained in public health settings. So these are some areas where I just wanted to focus. And so you can add on, sir. So
yeah, perfect. Actually, probably some of the practices that we forget now these days, like the KMC, which has been now reinvented, but other ways, and then the breastfeeding, now exclusive breastfeeding, the first breast milk, giving the first vaccine to the baby, the microbial advantage that you provide with that, and the feeding practices, all these things which are actually contributing indirectly to preventing sepsis. And of course, we still, when we talk about all hi-fi things, that is not enough. Actually, hand hygiene has to be stressed in whatever form. We talk about hand hygiene all the time, but whatever is the talk that is happening is not enough. We need to stress more and more on hand hygiene. We need to also probably look at the actually audit our policies and then fill the gaps. So that is a concept of quality improvement. Actually, whatever, if there is a gap in the bridge, you try to repair that so that you can cross over. So probably you need to see where we are going wrong in our unit, and then you try to work on it. So we have now very scientific systemic method to do it. Your so-called PDSA and the various methods of improving quality of care. So all these we need to incorporate if you want to improve the prevent sepsis. Now let us go on to the, already time is short, I think. So the last last question probably can be on this pandemic. Now COVID infection. So now we have a imminent third wave, and probably this is again a scenario where now we can anticipate more and more problems. So let us be very, we'll talk only about the basic concept, because this is the area where people have their own opinion. Let's only what is universally accepted things in management of a COVID positive mother, baby asymptomatic and baby symptomatic. Let's just discuss that and hand over to the moderators, I think, because already lack of time. Yeah.
So fortunately, I think despite these two waves hitting us, I think the impact on pregnancy and the neonates, I'll say, compared to the other age groups, the impact has been much less. So to a larger extent, actually, what we have done over a period of time, what we have learned over a period of time is that we need not be too restrictive, and we should not be actually moving away from the many standard practices or good things what we used to do to improve the neonatal survival. Whenever, especially a lot of perinatal practices, which were earlier thought to be like to increase the risk of a transmission, they've all been found to be untrue. So bottom line, so okay, you need to have to prevent transmission as much as possible. You need to establish separate delivery areas. You need to have separate set of personnel. You need to have separate areas for level 1, level 2, and even if required, level 3 care, depending on your setting. So again, the design is setting up of all these areas. The most important is the personal protection, PPE. How do we do all these? So you need to look into all these. That establishment has to be there, whatever be the setting. Practices like, and in no way, in most of the cases, in 99% of the cases, COVID, even though the mother is infected with COVID, if she is remaining asymptomatic, if she's not having a severe form of COVID, hardly there is any indication to alter, to make any decisions about the termination of pregnancy or a mode of delivery. We just go ahead with an obstetric indication, and the mode of delivery is also decided only by the obstetric practice. Perinatal practices, all good perinatal practices, what are in vogue, please make sure you do delayed cord clamping. Don't do away from delayed cord clamping. Can we start early? Can we deliver over the mother's abdomen? Very much you can deliver over the mother's abdomen. If it is a small baby or low birth weight baby, whenever you want to start an early KMC, can we do KMC? Yeah, please do KMC. So all these good practices, what we have learned over the period of time, just for the sake of COVID, don't think of doing away. All these are very much important, even in protecting babies who may have been infected with COVID, and they do not increase the risk of COVID significantly. So please we need to continue these practices as far as perinatal practice is concerned. We hardly had any symptomatic neonates. I am aware of a few cases of this multisystem inflammatory syndrome, or very few COVID pneumonias report, 1 or 2 reports from Chennai, from some hospitals. At large, these babies are remaining asymptomatic. We just do, what we do is that, okay, again, breastfeeding, we allow the mother, we are in unit who are exclusive, we are still following a policy only of exclusive breastfeeding. We don't have any other option. We continue the same during we had more than 1,000 COVID positive mothers delivered in our hospital. All of them were only breastfed. Nothing happened to all these babies. Let the mothers, just ask the mothers to practice proper hand hygiene, use a proper mask during feeding. They are all roomed in along with the mother only. We didn't separate those babies from the mother once they are born. We just screened them. Just again, this is an academic institute. If just to find out whether perinatal transmission is happening, we're doing a screen at 48 hours, and then another screen around between day 4 to day 5. But they were hardly useful in any way, because all are remaining asymptomatic. Whether they're positive or negative, we had the same management. So apart from continue all good practices, have separate areas, don't increase the risk of infection. I think these are they were the major areas that I want to touch upon.
Great. So one last question. This is, I just opened the chat box and there's a flurry of questions. I don't know how we are going to manage. Last question I just saw. Any role of doing RT-PCR after 24 hours in newborn?
The role, I just said that, sir, it is only if you're interested in finding out whether the transmission has happened through the placental route. Because that is, again, even if you're doing that, that means you have to do it less than 24 hours to be precise. Because even if you're doing after 24 hours, this may be an infection that would have got, even it's maybe a postnatal transmission, which is very early. You can't say it has happened in transplacental. It's more of an academic exercise. It doesn't help much. It is not mandatory, I'll say, at the moment.
Great. So the message should be that, like you manage the babies the same way as it was. Just forget the COVID. We have some so-called infrastructural problems and things like that, but with that we need to, on an individual basis, we need to sort out. The basic concept is baby should not be denied its basic rights just because mothers are COVID positive. That should be our ultimate aim. Now, thank you everyone. It took 15 minutes extra for this. And we try to do it in the current style of the Instagram style of interview, one person interviewing the other. I don't know how effective that does. Please give your feedback, because gone are the days of lectures and slides. So probably the Mangala did not do my part of host very well. Anyway, I hope we were able to convey some messages in this session. So the basic the concepts still remain the same, and probably antibiotics, if you are going to use them, think twice before starting, and then if you start, use the narrowest spectrum possible, hit hard, hit the correct dose, not homeopathic dose, and then stop as early as possible. You don't need to wait for the sacrosanctum days of 48, not even 48 hours, 3 days, 5 days, 7 days. You don't need to wait later. The moment you are convinced there is no sepsis, stop. That's it. Because the baby is under your care only. And then, of course, the antibiotic discussion can take ages. there are a lot of more discussion, lot of questions, and there are a lot of different opinions. But as we said, whenever there is a difference between science and practice, there is scope for discussion and debate, and that is what we should be doing if we really want to improve the outcome. So, with those words, we have Mangala. You want to say anything before?
I just wanted to again thank. Just will be open for taking up questions. Thanks for opening up new platforms and giving me an opportunity to learn about these newer ways of interaction. I just totally enjoyed interacting with you. Thank you.
Thank you. It was truly, whatever others liked it, I truly enjoyed the chatting with you today. Now, over to the moderators.
Thank you, sir. So it's an excellent session where we have seen the evidence-based medicine put into direct practice. Thank you, sir, for your excellent session. But we have a few questions coming up, and I will thank Naveen sir for handling the chat box well, because most of the questions are answered in the chat box itself, and most of the questions are related to CRP. It is just catch the imagination of all the doctors, I think. So, I think we had to take a final comment about CRP by each faculty about the use, the prognostication and the practicality of CRP in sepsis. So each faculty is a request to have a personal comment about the use of CRP.
Who want to go first?
Naveen sir, if there's Naveen sir, because slides were not audible at that time.
Yeah, CRP not useful when you are going to start antibiotics. Zero use of CRP when you're going to start antibiotics. If you already decided to start, no use of CRP. If the baby is non-sick after 48 hours, you have decided to stop the antibiotics, then again spare the CRP, it will confuse you. If you have a baby who is going to remain, for example, a 30-weeker is on ventilator, 48 hours after baby is otherwise well completely, some of my team members would not be willing to stop without seeing a negative CRP. But whatever is there about this old teaching of 2 CRPs, which are serially negative, is a very, very old paper and it's not contextual at all. So there is no role for doing 2 CRPs. This is my personal opinion, but I'm willing to hear from what Mangala does and what Manoj does and any other expert in the team.
Thank you, Naveen sir. I'll fully just go by what Naveen sir has said, but only 1 or 2 points that I would like to add is that many people think that CRP is, might help to differentiate a baby with infection from other conditions, especially when there are other comorbidities. So CRP can be positive in many other conditions, asphyxia, meconium. So many things can cause a positive CRP. That's why we always say positive CRP doesn't mean sepsis. So it doesn't help you to differentiate. So only sir said, I just want to emphasize that if you want to rule out sepsis, so you think that, okay, this may be something else and this is not sepsis, and you just want somebody to support the diagnosis, you want to just again, increase your confidence level, that is the time maybe you do a CRP. A positive CRP doesn't give much information. And one situation where we do use, or I personally use CRP is that when baby had clinical features of sepsis, but if it is a culture negative sepsis, we didn't have the culture positive, and the CRP which was done, but again for some indication, I don't know whether the CRP, I won't go for CRP at that time. You don't need to do a CRP, but if a CRP had been done, and that or whether it was done or not, mostly we just go with the clinical symptoms of the baby to decide the duration of antibiotic in that case. The challenge always is in a baby who had a likely sepsis like clinical course, where we have given antibiotics but the culture was negative, the so-called culture negative sepsis. So what should be the duration of antibiotics in those conditions? So especially in small babies where it's not easy to totally, I just sometimes do a CRP to be sure that, okay, this fellow is not having symptoms, or whatever the mild symptoms this baby is having is not because of infection. So before stopping antibiotics safely, I do a CRP to convince myself. Again, it's again a personal choice in a limited situation.
Correct, sir. Thank you, sir.
See, we live in a real world. We have extremists and moderates. And like, if you really want to argue, you can argue either way. What is the probability of winning or rather confirming sepsis is, somebody can say, it is like tossing a coin, because 50% you are right, 50% you are wrong. So then why do the test? Why toss a coin and see and say, okay, baby has sepsis or baby has no sepsis? This is one sort of argument. Now, what is the science behind it? CRP is not useful for ruling in sepsis, which means that to start antibiotics, CRP will not help you. To ruling out sepsis, there is some evidence. Suppose you have a negative CRP and baby is improving, you don't need to continue antibiotics further. But if baby is not improving, you will not do a CRP at that time. Even if it tells you anything, it may not help. So that is what is called, it can help you in ruling out sepsis. But again, this, do not take it totally. The studies which I am quoting are all not from our country. But then this is something for you to go by. And I always believe, be a moderate. Don't go to both the extremes. Use it as a adjunct with other things. Do not start antibiotic just because of CRP, but do not totally neglect it also. It has its own role, like any other factor. We talked a little bit about sepsis calculators. It has its role. It will give some weightage to a decision. That's all. That is not going to be the only factor. And the more glory, somebody I just now saw one question on value of procalcitonin. So again, this is again the similar scenario. There are studies which say the superiority. Some people say it is again not very good, and probably I tend to believe that procalcitonin is not superior to CRP. There are studies which say it's superior. So it is like that. So this is we live in a real world. We need to really, there is no black and white in neonatology. There are only shades of grey. 1 + 1 is not 2 always.
Thank you, sir, for excellent answers. And one last final question, a very practical issue. This is about the management of foul-smelling umbilical discharge, umbilicus. And you want to start oral amoxicillin or local mupirocin, or how you to go about this?
To whom?
Anybody can answer, sir. Manoj, sir, or
foul smelling umbilicus per se. Anyway, there is no question of starting oral antibiotics. That is straight away out. Now, if you are going to treat, you need to treat with IV antibiotic. But the decision to treat is a very, very weighted decision. You are not, just because the umbilicus is foul smelling, you may not. You can try local measures first, like saline or probably local antiseptics. Local antibiotics are these days not recommended because of various reasons. But having said all these, if baby has other features, then you can start IV antibiotics. Otherwise, probably just because it's foul and straight away jump into starting antibiotics. If you're going to what is amoxicillin? No, probably I would not start. If at all you're given a choice between oral amoxicillin and mupirocin ointment, I'll go for mupirocin ointment and then see. Mangala?
Yeah, yes, sir. I think somehow that one thing that we have seen, which is becoming rare over a period of time, is umbilical sepsis. Somehow we don't see that much cases of umbilical. Maybe the practices related to handling the umbilicus, which would have been the main reason, applying so many things on the umbilicus. And that is not happening nowadays, I believe. Even in our unit, the incidence of umbilical sepsis is almost, we hardly see umbilical sepsis nowadays. That's where maybe even though people are behind us to use fluoxetine, many things can be applied in the umbilicus, we are very hesitant to take up those drugs, because even dry care seems to be perfectly okay, and infection is much less. So purulent discharge, if you're sure, because if it is foul smelling and you have witnessed it is purulent, obviously look for other signs, like whether there is more. One other important sign is definitely the erythema and induration. If this purulent discharge is associated with erythema and induration, or if you think that the baby is having a pain, or when you are touching the place, you know that actually that they are more likely to have an umbilical sepsis. The question is whether you treat as if those signs are there, whether you treat as a local sepsis or as a systemic sepsis. And this is one area where I think if there are clinically, we'll do a thorough clinical examination. If there are no clinical signs of sepsis, you are convinced that clinically there are no signs, I will use again CRP in this scenario to convince myself that I don't need to start intervention. That means there is no systemic sepsis. If I'm convinced there is a local sepsis. If CRP is not negative, I'll definitely consider taking cultures and starting antibiotics. Otherwise, I will definitely send a swab. I'll just, if I'm have a doubt, I will not go for intravenous antibiotics. I'll just put the baby under observation, use topical antibiotics, and maybe wait for a CRP report and send the swab for pus culture and so gram stain.
Perfect. Actually, one point that was made was like leave the umbilicus alone. Umbilicus, how does the umbilical cord fall? By colonization. So bacteria has to grow in it for it to fall. If you use unnecessary antibiotics, it is going to delay your cord fall. So if you leave it dry, don't do anything, it will fall. Do not, and then such units which follow that, we hardly see any umbilical care. Only if you just unnecessarily start antibiotics for every baby, then the cord falling will take time. Then there is every chance that it will get infected.
Okay, thank you, sir, for the excellent answers. And now we are completely run out of time. And hope you enjoyed this session. Thank you, Mangla sir and Manoj sir. And now I think we have discussed all the questions, and we are very many take-home points, and we cannot enumerate or summarize it as a single sentence. So many take-home points, and those who are joined will be extremely happy and will be enriched with the management of sepsis. So, and I request Pavan, the Secretary of NNF Thrissur, to propose the official vote of thanks. Over to Pavan.
Yes, thank you, Dr. Srijit. So let me take this opportunity to thank NNF Kerala. We have organized this meeting under the NNF Kerala Action Plan. The meeting was organized by NNF Thrissur. Let me thank our President of NNF Kerala, Dr. Ravi sir, Secretary Dr. LB, and Treasurer Murli sir. Also, let me thank our President of NNF Thrissur, Dr. Rajagopal sir, and my team, which includes our Treasurer of NNF, Dr. Manjusha. And today's faculty, we had an excellent session by eminent faculties from like Dr. V.C. Manoj, Naveen Jain sir, and Dr. Mangla Bhairadi. Thank you all for giving such a wonderful session today. And we all enjoyed the session, and it was a very useful one. And extending my thanks to the moderators, Dr. Srijit and Verma sir. And once again, thanking all the delegates for participating in today's event. And see you all for the next meeting. Thank you so much.
Thank you, Dr. Pavan. Now I request Dr. Ravi, President, to close the session.
Unmute.
Yeah, it was truly a very fulfilling experience. It was rather than usual theory-based talks. It was a really wonderful interaction, and I think everybody has gained a lot from this discussion. I think this is the way forward, and we should carry on similar discussions in the days ahead. Thank you very much, Naveen, Mangala Bharati sir, and Manoj, and the entire NNF team, as well as the IAP office bearers. And we have good numbers participating. It's really encouraging. I think the next CME will have more numbers. And before we wind up, I request everybody to join NNF once again, because the days are running out. The limited offer will be only for a few more days. So I request everybody to join. And of course, the MBFHI program, your wholehearted support and your participation will go a long way in getting re-accreditation for MBFHI. Thank you and good night, everybody.
Thank you once again.
Thank you so much, Mangala, Naveen. Thank you, friends.
Bye.
Thank you, Naveen sir, Manoj sir, everybody. Good night. Thank you.
Thank you, sir. Thank you all.
Hi. Close it. We'll close us.
Sure.
Yeah.